Asplenia and Polysplenia syndromes represent the two primary phenotypic expressions of heterotaxy, that is situs ambiguous, resulting from a failure to establish normal left-to-right asymmetry during embryonic development. In clinical practice, these are best understood through the framework of cardiac isomerism, where paired structures exhibit bilateral symmetry of either the right-sided or left-sided morphology. Right atrial isomerism, Asplenia syndrome. Right isomerism is characterized by the bilateral tendency of organs to develop right-sided characteristics, that is bilateral right-sidedness. From a cardiac perspective, this syndrome presents with highly complex cyanotic anomalies that often require early surgical intervention. Key cardiac and vascular anomalies. Atrial morphology, bilateral right atria. Both atrial appendages are broad, triangular and have pectinate muscles extending around the entire atrioventricular junction. The coronary sinus is typically absent. Atrioventricular septal defects, almost universally present as a complete atrioventricular septal defect with a common atrioventricular wall secondary to severe endocardial cushion defects. Ventricular and great artery anomalies, high incidence of a univentricular heart, single ventricle morphology. Double outlet right ventricle DORV or transposition of great arteries are highly prevalent. Pulmonary outflow obstruction. Severe pulmonary stenosis or pulmonary atresia is present in the vast majority of cases, significantly restricting pulmonary blood flow. Total anomalous pulmonary venous connection TAPVC. The pulmonary veins fail to connect to the morphologic left atrium as it does not exist. Instead, they drain anomalously into systemic veins like superior vena cava, inferior vena cava or portal vein, and this connection is frequently obstructed. Systemic venous return. Bilateral superior vena cava is common. Inferior vena cava and abdominal aorta typically run on the same side of the spine, juxtaposition. Left isomerism, Polysplenia syndrome. Left isomerism is characterized by the bilateral development of left-sided characteristics, that is bilateral left-sidedness. While cardiac defects are structurally less severe than those in right isomerism, they carry significant morbidity, particularly regarding the cardiac conduction system. Key cardiac and vascular anomalies. Atrial morphology. Bilateral left atria. Both atrial appendages are narrow, finger-like and hook-shaped with pectinate muscles confined strictly to the appendages. Interrupted IVC with azygous continuation, the classic vascular hallmark. The hepatic portion of the IVC is absent. Hepatic veins drain directly into the floor of the atrium, while systemic venous return from the lower body routes via an enlarged azygous or hemiazygous vein into the superior vena cava. Septal defects, atrial septal defects, often primum or secondary type, and ventricular septal defects are common, though an intact ventricular septum or partial atrioventricular septal defect is more frequently seen here than complete atrioventricular septal defect. Pulmonary venous return, partial anomalous pulmonary venous connection PAPVC is common, with pulmonary veins often draining symmetrically into both morphologic left atria. Obstruction is rare. Conduction system anomalies. Because a morphologic right atrium is absent or malformed, the sinoatrial node is frequently absent or hypoplastic. This leads to a high incidence of congenital complete heart block and bradyarrhythmias, often requiring early pacing. Outflow tracts. Left ventricular outflow tract obstruction, aortic stenosis or coarctation of the aorta occur more frequently here than pulmonary atresia. Here is a comparison, though quite a lot of variations may be noted in clinical practice. Atrial appendages, bilateral right, broad triangular in right isomerism or asplenia, bilateral left, narrow finger-like in left isomerism or polysplenia, sinoatrial node, duplicated, dual pacemaker site in right isomerism, absent or hypoplastic, high rate of complete heart block in left isomerism, inferior vena cava, intact juxtaposed to the aorta in right isomerism, interrupted with azygous continuation in left isomerism. Pulmonary veins, TAPVC frequently obstructed in right isomerism, PAPVC or normal drainage in left isomerism. Pulmonary outflow, severe stenosis or atresia common in right isomerism, while normal or mildly restricted in left isomerism. AV wall, common AV wall, complete atrioventricular septal defect in right isomerism. Two AV walls or a single common wall which is variable in left isomerism. Associated ventricle, single ventricle common in about 50% of right isomerism. Two ventricles are more common in left isomerism.